Hello.
Let me step out.
Hello. My name is Dr. Scopazzi, and I will be reviewing the Class 3 restoration, specifically using amalgam as the restorative material. Amalgam was introduced in the U.S. at around 1830, and it is composed of silver, tin, zinc, and mercury, hence the name amalgam. The advantages of amalgam is that it's cost-effective for the patient, it's rather easily used and manipulated by the practitioner, and it can be polished over time, therefore extending the life of the restoration. The disadvantages are that it takes a specific thickness or depth, therefore the tooth structure needs to be removed for a certain depth for the filling to have its strength. Its color is a disadvantage, and some medical professions believe that the mercury that is in the amalgam may contribute to some of the diseases like multiple sclerosis and others. I have to say that today there are still practitioners who feel that the amalgam is an effective and useful restoration and still use them today. Other dentists remove all the amalgam in the patient's mouth and restore with the ceramics and the composites that we have today. In order to understand the preparation and the fill of the Class 3 restoration with the amalgam, you must understand how the dentist prepares the tooth. Class 3 restorations are specifically located in the anterior teeth. They are located at the contact point or slightly below. They can extend buccally and lingually on the tooth surface. Therefore, access is a challenge for this restoration. And normally, the dentist wants to conserve the facial portion of the tooth, therefore he accesses the decay from the lingual portion. So not only is the cavity located in a difficult position, but the access of the cavity is solely, if possible, on the lingual, from the lingual area. Therefore, both of those criteria make this somewhat of a challenge. To restore the tooth, which will be what you will be doing, you need to have a matrix system. For the Class 3, the matrix system is the matrix itself and the wedge. There are commercial fabricated matrix. There are commercial matrix systems already prepared and wedges. Wedges come in small, medium, and large, and you will use them appropriately in regards to the size of the embrasure and the location also of the tooth. The matrix system consists of the matrix and the wedge. You can purchase commercial matrix, or you can make them yourself with the matrix systems and the Tafelmayer matrix. No. The Class 3, the restorative portion, will be what you will be responsible for, and you will need to have a matrix system of the matrix band and the wedge. Wedges come in small, medium, and large, and you will need to select them according to the embrasure size and the proximal area of where of the decay. The matrix system consists of the matrix band and the wedge. Wedges come in small, medium, and large. You must choose the correct size of the wedge, because if you do not, the embrasure area will change in its contour, either allowing food to get impacted in the area if you use too large of a wedge, or if you choose too small of a wedge, then there will be an over contour of the material, which will lead to constant gingival irritation. But in this slide, you will see that we are restoring the distal portion of tooth number 9. There is a matrix band in place, as well as a wedge in the embrasure area. You must burnish the matrix against the contact point of the adjacent tooth to ensure that you will have a good contact, normally a snap of the floss that goes through the contact, to make sure that food is not going to be impacted in the area. I am going to discuss now the way that you will be restoring the tooth with the amalgam. The dentist will have already prepared the tooth, and he will be preparing more of a box-shaped preparation. The box-shaped preparation ensures that the facial or the buccal, the buccal line angle and the lingual are parallel at 90. The dentist will have prepared the tooth having the facial and the lingual surfaces parallel and prepared. The matrix band, the matrix system consists of the matrix band and the matrix. The class 3 amalgam matrix consists of a matrix band and a wedge. The class 3 matrix system consists of a matrix band and a wedge. There are already commercially produced smaller matrix that you can purchase, or you can fabricate them yourselves depending on what is your preference. It is important that when you choose the wedge, you choose the correct size wedges. They come in small, medium, and large. The wedge is supposed to recreate the embrasure between the adjacent tooth. Plus, it also ensures that the amalgam is not going to be overfilled in the area or even seep through the preparation. It is very important to choose, like I said, the correct size, because if you choose too large of a size, the contour will not be correct. It will be more of a straight line than following the contour of the tooth. If you choose too small of a wedge, there is going to be too much material, and instead of following the contour, you will have more of a bulbous shape at the gingival margin, and that is going to cause the patient to have gum irritation in that area constantly. So the preparation itself is finished, and now it's time for you to fill the preparation. Therefore, you are going to condense the amalgam by triturating it. Once it is completed in its trituration, it should have a semi-gloss film. It either is in a circular or egg-shaped ball, and you will use your 1-2 condenser. You will fill the 1-2 condenser, and using the smaller condenser at a 45-degree angle, you will place the amalgam in the developmental groove. With the 1-2 condenser, you will, at a 45-degree angle, you will place it in the retention areas that the dentist has prepared. They're usually on the lingual, axial line angle, and buccal axial line angle, as well as some dentists also put a retentive groove at the actual floor of those line angles. As I said, the amalgam is placed in these retentive areas, and you will take your 1-2 condenser using the smaller size condenser. You will be using a stepping motion that you will be overlapping each step and systematically going down one line angle to the next. And at that point, when that is finished, you will take the larger end of the 1-2 condenser, you will place it on top of the amalgam that has already been placed in the tooth, and you will use again the stepping motions. If the preparation is large enough and you can use 3-4 condensers, you're welcome to do so. But what you are trying to ensure is that there are no voids or air bubbles or gaps as the amalgam is being condensed. You will condense the preparation slightly past the margins because you want to be able to carve back the amalgam that you have placed. Once you have the entire tooth filled with amalgam, there is normally a setting time. There's an initial setting time of the amalgam, and then there is a final set of the amalgam. You will be working with the amalgam completely in the initial setting. Once the amalgam starts going into the final set, you do not want to be touching the amalgam. Normally only scratch marks, and it does not carve well. It's best that you will have finished carving it before it starts its final set, and that is at the 3-4 minute mark. Depending on some amalgams, the doctors that you work with are faster set than others. That is something that you need to check with them. But at that point, you have your amalgam that is completely set. You will use your explorer, and you will gently, in this case, from the incisal edge, you will work it down, making the distal marginal ridge contour all the way to the gingival, and that is making the contour of the tooth, plus it is also separating the amalgam from the matrix band. At this point, you will remove the wedge, normally with a cotton forceps, and rather than just lifting the matrix band, you will extend the matrix band on the buccal, on the facial and lingual surfaces so it's a straight line, and then very gently you will tease it out. You do not want to be rough because you may break the marginal ridge as it is setting. At this point, you need to establish the proper contact. The proper occlusion. Therefore, you take your articulating paper and gently you ask the patient to bite down. You can even guide the lower jaw as to make sure that the patients don't bite down too hard and to break the restoration if it's slightly high. You will be adjusting with the Tanner carver, the discoid cleoid, or whatever amalgam carving instruments your dentist may have, and you remove all high spots, especially on the marginal ridge. You do not want to have a contact on the marginal ridge. Once you have proper contact and occlusion, the restoration is finished. The contact point is also the contact point is also important to make sure that the patient can floss properly. You will take the floss, and rather than snapping it through the contact, you will seesaw through the contact. You go all the way down to the gingival margin, and you can burnish the amalgam against tooth. But at that point, the floss does not come back through the contact point, because you can actually open the contact point by flossing it too vigorously. So once the floss goes through, either remove the floss facially or lingually, and at that point you should no longer touch the contact point. Amalgam can be polished, but it needs 24 hours to have a proper set, so the patient can return either at a recall appointment. The amalgam can be polished, or you could have the patient come back within a 24-hour period and polish the amalgam. Now I'm going to be discussing the slot or box preparation of the prep. As you can see, we have a bicuspid, and we have a wedge, this time coming from the facial to the lingual. And as you notice, the occlusal groove is still intact. The dentist has not removed it, and there is just, it looks like a rectangular box. We prepare these type of fillings now to conserve as much tooth structure as possible. If you were to look at the preparation of the tooth that we just saw before from the contact point inward, you will see that there is a definite groove from the lingual line angle, from the actual lingual line angle to the buccal lingual line angle. There are grooves that go into the dentin, as well as on the axial pulpal floor. There are little, it's not a groove, but they're little indents. Those are essentially undercuts, and what the preparation, how the preparation will hold the amalgam is by the parallel walls and these undercut grooves. Okay, the larger the decay, it is more difficult to solely have this box form. It depends, it's going to depend on the dentist's determination if the occlusal surface needs to be incorporated in the filling. It goes, the smaller the filling, more likely it's a box. The larger the filling, the more extension of the box, the larger the box, more likely the developmental occlusal portion of the tooth is going to be incorporated in the filling. Moving along, this is the slot. This is more of a diagram that you can clearly see from both sides, those grooves that are in place to ensure that the filling is not going to pop out or break. Facial and lingual retentive grooves are a must. Without them, the filling, once you pack it in there, will stay, but once the patient starts eating and chewing and actually using that tooth for mastication purposes, it will either fracture or it will completely fall out completely. In the next slide, you will see the diagram even more so showing how the preparation from the actual wall, which is the one with the dotted line is an indication that there is the pulpal wall, and then there's the gingival, and there is definitely a step down. Again, you will see on the buccal and lingual the retention grooves in there. So we need to condense in a step-like fashion. We need to make sure that we burnish the matrix band against the adjacent tooth in order to establish a firm and strong contact. We need to carve at the proper time in the initial set and not when the amalgam enters the final set. We need to maintain the integrity of the tooth in its contour, in its shape, the embrasure size. We need to make sure that the marginal ridges have no occlusal contact. With all of those in place, you should have a successful restoration. The patient will be happy, and you should be pleased at your ability to restore the tooth to the best of its function using the material with its limitations. If you have any questions in concern to this lecture, we will be able to review it during the Zoom sessions, and also when we are going to be doing our hands-on lab. You can bring questions that you may have, and I do believe it's going to make a little bit more sense when you actually are doing it and visually seeing what is going on. I hope to see you soon, and take care, and thank you for your attention. Bye-bye.